Well, welcome everybody. I think we're in for a treat. This is a wonderful double header we have here with Dr. Elyse Park and Dr. Peter Wayne. I know them both well. They're wonderful friends and colleagues. So I'm going to introduce Elyse, and she'll be talking about the stress management and resilience training program, the relaxation response model, and the treatment of integrative care. And Dr. Park is a professor of psychiatry and medicine at MGH and Harvard Medical School. She's a health psychologist and behavioral scientist. She founded the Health Promotion and Resiliency Intervention Research Program here at MGH in the Mongan Center. And it's an initiative of both the Department of Psychiatry and Medicine. She directs the behavioral research at our Benson-Henry Institute. She created the BHI's evidence-based stress management resilience training program and developed a cadre of multidisciplinary investigators dedicated to resilience and the clinical delivery of it and the clinical research in it for vulnerable populations. She's adapted resiliency treatment to diverse populations and settings and has conducted many trials assessing the SMART program with clinicians, parents, patients with chronic medical illnesses. So without further ado, Elyse.
Thank you, Greg. So I'm going to keep this. It's interesting being introduced by Greg, who's the paternal figure of this program. But I think for the sake of this presentation, I'm just going to give you an overview of kind of what our resiliency work looks like and theoretical basis of it. I'll give you a summary of some areas that we're heading toward in research and what we're doing, but really want time for Q&A. And it's exciting to be at the McCance group. I worked with some of you as last year, I'm putting forward some applications for looking at COVID survivors. So, but this is the first time I've really been with you all. So thank you for the invitation. So when BHI came over, Benson-Henry Institute, and really this is the first lecture we're giving since the passing of Dr. Benson, who was the really the icon in the field that brought Greg and myself and others in. Dr. Benson brought his institute over to MGH and over 10 years ago, and really took our mission was to take this work that was based on the physiological state of the relaxation response into clinical care and figure out how to protocolize it and how to really understand the basis of the elicitation of this response about leveraging mind-body research to help people live more resilient lives. So one of the things that we put to task was, well, what is resilience and how do we define it? And it's something we're working on in one of our studies and our initiatives with Greg's Resiliency Think Tank, which is an MGB effort, and with some colleagues over at the Harvard School of Public Health. We're hoping to really get some support to look at this nationally as how do we understand what resilience is? How do we understand how to enhance it in individuals? And how do we understand how to measure it? So that's been really the crux of our work. So briefly, the literature, we have followed the literature that consistently talks about resiliency being the ability to bounce back in the face of stress and adversity. And clearly the past 2 years, and now the reintegration period was a test for many individuals in that. We focus on resiliency, not as a response to a trauma, but really as the capacity to adaptively overcome stress while maintaining normal physical and psychological functioning. So whatever one's base is, how do they maintain that despite challenges? And I think the thing that's very unique in our work is traditionally resilience was conceptualized as more of a static personality or cluster of traits or something that was more of a response to trauma. But increasingly, some conceptualizations really see it as something that's modifiable, which is how we look at it. And we really see it as something that is modifiable, but also we see resiliency as a response to everyday stressors. And so that one's resiliency can be tested. One's resilience is tested for bigger life events, things like war or acute illnesses or situations. Responding to that adaptively is resilience, but resiliency is really being able to cope on a day-to-day basis with everyday stressors that are ongoing, and how do people live more purposeful, healthier lives within those stressors. And one of the things we do when we first work with patients is we ask them about their stressors and then how they adapt to their stressors, what tools they have, how they cope with it. And then over time, we ask them to track that. And what individuals see is overall, they don't really change their objective levels of stress, but they are able to change and have the tools of how they respond to them. So our work is built on the foundation of the diathesis stress model, which talks about a resilient individual is the outcome of one's life experiences and one's inherent capabilities, and that it's an interaction between one's inherent capabilities and skills and one's environment and what they face, which determines whether one's resilient. And a resilient individual is not necessarily one who does not have adversity, or is not necessarily one who faces adversity well, but it's one who has the abilities and skills to be able to face adversity. So this was Dr. Benson's work of the relaxation response was founded based on the kind of the counter to Dr. Cannon's work, who is also in Harvard fight response, which is our responses to acute stressors, which is kind of the foundation of the earlier stages of resilience literature, is how do people respond in the moment, or how do people respond to emergencies and traumas, and that the stress response prepares our body for a physical reaction to an actual threat, and that we respond by fighting, by fleeing, or by freezing when we're unable to respond. The allostatic load is the balance of ongoing stress, where people are constantly choosing to fight, flight, or freeze. And when we're chronically stressed, the allostatic load is the definition of the wear and tear of being in that constant state of flight, response, or freeze. So this is what the normal versus maladaptive responses to stress is. I use normal kind of with some liberty. This is work by the former Dr. McEwen at NYU, which shows allostasis is the balance where a stressor occurs, and then we come down to baseline when we're able to adaptively respond to it. But allostatic load, I think the way a lot of folks have looked the past 2 years, is that particularly the uncertainty in our lives, is that the wear and tear is constant, that we never really return to baseline, that we start at an elevated level of hypervigilance of response to a stress, and then we continue, so that we're kind of responding adaptively to the stressor, but our baseline is so heightened that we end up having some physical wear and tear on our bodies, which shows up in terms of our physical and psychological quality of life. So these are different ways to respond to stress. This is the normal response. A stressor happens, there's a recovery period. This is people who kind of go from 0 to 60, where any stressor, they have a very strong reaction to. This is, I think, what COVID looked like a bit. There's a stressor, and then over time, there's kind of a prolonged response, and people never come back down to baseline. And then this is what depression looks like when people are, when people stop responding to stress, are unable to respond. And in our clinical work on resiliency, one of the things we start to teach people is to understand how they respond to stress and when they elicit these different perspectives. It's not black and white. All of us have different inherent stress responses. Dr. Benson's work was focused on developing the relaxation response, which is a form of meditation in which we're able to reverse the constant wear and tear of stress. And for those of you who are, I'd say over 50, this red book probably looks familiar from your training days. This was a book Dr. Benson wrote in the 1970s. 1977, the relaxation response was considered very much cutting edge, really the first person to talk about the connections between mind-body research, was based on his work with cardiac patients and understanding the characteristics that he was seeing in his patients that were consistent with high levels of stress and was causing, he believed, an exacerbation of their cardiac state. And so this is the stress response, and then Dr. Benson's very simplistic overview is just showing a downregulation of the physiological features of being in stress, and really felt at the time was incredibly novel that one could reverse those physiological states. And more really importantly is that once one did, then they were open to learning other skills. This was our first model. Our work is based on the relaxation response elicitation. We take a very pluralistic perspective of it. If you see now, there are 8 types of RR elicitation strategies. Some are body-mind and some are mind-body. In our work, we have a very patient-centered approach, expose people, and our belief is that people can start living, moving toward a more resilient life once they start understanding and practicing some of these RR elicitation practices and start purposefully engaging. The second component of our resiliency work is stress awareness. Once one is in the RR state, they're able to step back, understand how they respond to stress and the different components of responding to stress, identifying behavioral, physical, emotional, cognitive, and relational. And then the last component is really based on positive psychology and post-traumatic growth, where we're proactively buffering stress through healthy lifestyle behaviors, positive attitudes, reappraisal of thoughts, and being aware of one's connectedness. So this is kind of the crux of our model. This was our first model, and then we simplified it, but our goal is to promote the relaxation response, decrease the stress response, and promote growth enhancement, making individuals more resilient. And in turn, when individuals are more resilient, they are able to enhance these strategies. And we've done research supporting this, and we continue to do that. And that's our goal right now. This is a simplified version of our model that we use now of the resiliency skills, the processes, and the resiliency as an outcome. We're also beginning to use resilience longer term outcomes. We're collaborating with folks at Harvard, looking at flourishing and really trying to look at the long-term effects of being resilient. But in our clinical work and our clinical trials, we're looking at assessing these skills in intervention, looking at measuring the processes, and looking at people's self-reported and biobehavioral reports of resiliency. This is our model. Okay. So the theoretical underpinnings of the model, I'll just go through those in the time that we have and really give you just some examples of the work that we do. So we believe that those stress management growth enhancement strategies interact with each other to promote resilience and are bidirectionally related to resilience. So as we work with patients, we work with them to identify an RR elicitation state and then introduce the stress awareness exercises, the growth enhancement, the adaptive strategies, and people purposefully build those. The difference, these strategies, none of them onto their own tend to be unique, but the blending and the constant practicing of them and the proactive use of them becomes a powerful tool for people. It becomes part of their vocabulary, it becomes part of their day-to-day lives. The stress management growth enhancement processes are distinct from the concepts of resilience, so they promote it and they're strengthened in turn by it. And then resilience is not only a function, though, of healthy distress management, so to be aware of your stress, but really being able to apply some positive strategies to that. So initially, what usually happens in our work is when people begin to elicit the physiological state of relaxation response, begin to learn some stress awareness strategies or stress awareness, they become more stressed because they're more purposefully aware of them, but then they're better able to use the growth enhancement strategies that we teach them. And I'll go through some of those. A lot of our initial work was based on figure out how to measure resilience, and we're still in the nascency of this, but the RS14 is a measure of a validated enhanced assessment of resiliency. And it contains 14 self-report items and was considered in many ways the gold standard for resiliency. It's based on the perspective that resiliency is a trait and that it promotes adaptive functioning. And we ended up identifying a measure, looking at the post-traumatic growth inventory and creating an updated version of that. The post-traumatic growth inventory is developed from the post-traumatic stress literature. It was developed actually by cancer patients looking back on their experience of having had cancer and seeing how they grew from that. So what are the silver linings, so to speak? What are the growth perspectives of that? Our measure of resiliency is based on that, where we ask people currently how they're doing on those growth processes. And we were able to correlate that with the RS14. So here are the domains of the resiliency measure: purpose, perseverance, self-reliance, equanimity, and authenticity. And our domains are a little different. If we look, these are some examples of the current experiences scale, which is the current assessment of post-traumatic growth inventory. I appreciate each day. I'm aware of my strengths. I take care of my health. I accept needing others. And these are the domains that we think that we intervene on in our intervention and have been validating this in our studies: is appreciation for life, adaptive perspectives, personal strength, spiritual connectedness, relating to others, and health behaviors. The difference between the current experiences scale and the post-traumatic growth inventory is that the post-traumatic growth inventory did not assess health behaviors, and we do. This is some work that was actually just published in Global Advances in Health and Medicine, where we looked at the different subscales of the CES, and we looked at them pre and post and saw that with a sample of patients that we used in clinical studies and at the BHI clinic, that there was positive movement on the CES total itself and most of the CES scales. And then we also looked at constructs. If we look at the top constructs, we say predictive positive correlations and predictive negative correlations. The predictive positive correlations were those growth and that second and the third core of our work, looking at different post-traumatic growth or growth enhancement constructs. We look at self-efficacy, mindfulness, coping, optimism, gratitude, empathy, and social support. And we saw positive correlations actually except in empathy. And then the predictive negative correlations is the second core that we intervene upon, people's stress awareness, where we saw negative appropriately correlations with our resilience measure on levels of perceived stress, emotional distress, worry, anxiety, and depression. So this is our program. It's an intake plus 8 weekly sessions. Each session intersperses our elicitation techniques, stress awareness, and growth enhancement strategies. And this is at the initial session, we ask people to identify for themselves to set their own goals. Or very health behavior focused. People set their goals in terms of resiliency, in terms of their health behaviors, in terms of their meditation practices. And so our first goal in our elicitation is for people to start achieving a practice of their own, however they define that. If it's 10 minutes a day, 20 minutes a day, half an hour twice a day, identifying what works for them in terms of what meditative practice works for them, to feel skillful and to experience this concept of an opening effect, meaning when one is outside of the stress response, they're more open to learning skills. And then the basic elements for eliciting the relaxation response is repetition of a simple stimulus, a word, a phrase, an image. Dr. Benson used to talk about religious objects or beliefs, and just non-judgmental attitude. We do use mindfulness and mindful awareness as a strategy to elicit the relaxation response technique, but I want to point out the difference in RR versus mindfulness is that RR is an awareness of a non-judgmental attitude, whereas mindfulness is more of an embracement and observation of one's experiences. We have different types of RR exercises. And then we do abbreviated versions of the RR exercise that people can practice throughout the day, which are called minis. Our second component, decreasing stress reactivity. We have people become aware of their stress warning signs, what resources they use, and how to take their negative thoughts and proactively modify them. And it's built on Lazarus and Folkman's transactional model of stress and coping that says how someone's experience of stress is really an outcome of the level of stress and their appraisal, and then their ability to really use the skills to match a coping strategy to the level of stress. This is our initial battery we have. We ask people to list their inventory at the end and the beginning and the end of our resiliency treatment with them about what they have, what resources they have, and what they use, what's stressful and what recharges them. This is our approach to cognitive.
Elyse, we have about 3 minutes. We have about 3 minutes.
Okay, I'm going to just flip then to the end to our work then. Okay, thanks, Greg. Yep. Okay, this is our third component. I'm on track, Greg. I got it. So this is our third component, the adaptive strategies. This is the growth enhancement. I talked about these 4 components of positive perspectives, reappraisal, social connectedness, and lifestyle behaviors. It's based on the post-traumatic growth literature that I mentioned. And it's not necessarily going to happen when someone's stressed, but really someone has to purposefully use these skills to cope with an event. It's also based on Selevine's positive psychology work, where we really focus on achieving personal growth and benefit finding. And we use humor for this. We use acceptance-based strategies, and we use the concept of appreciation, where people document the smaller things that happen on a day-to-day basis, because we are, the capacity of all of us, especially when we're stressed, is to focus on the negative. So this is a way of proactively documenting and experiencing positivity. And last, we teach people about social support, different types of social support. If they're utilizing their social support, often people have it, but don't access it. And then lastly, self-compassion. I'm going to end, this is just our word chart of an appreciation. If we had more time, what I do usually when I do these lectures is people give an appreciation from the day, but maybe you can all do that individually. When we start our meetings, we start with everyone giving an appreciation. It usually takes 5 or 10 minutes of the meeting. And this is our research directions. We just published our framework model with the current experiences scale and global advances. These are the measures that we use. We have one of our missions is to use core measures to measure our constructs. The next slide is just to show you how far we've come. This is the measures we've started with, and we're down to these. And we have a data repository that we keep for all studies and all patients at BHI, giving pre-post of these measures to test our model. These are our current behavioral research initiatives. We're working with a lot of different providers and patients and community-based populations. Sorry, it was a little quick. So these are just different populations that we've worked with. We have a cadre of interdisciplinary folks working on this. These are some of our clinical trials. John had a project with multiple myeloma. Giselle Perez and Daniel Hall are working on survivors. Christina Saros is working on older women with HIV. Daniel Hall is working on fear of cancer recurrence. Britton Mahaffey is working with perinatal women. Myself and Karen Coulthall work with parents of kids with special needs. We just got a HRSA grant, myself, Cordia Bannister, and Sylvia working with healthcare workers. And Lara Traeger is working with the Foundation on Senior Living Residents that was facilitated through BHI. And we're about to hopefully start a study with caregivers. So that's it. Our priorities are here. We're integrating more into cancer care, adapting to different populations, thinking about how to reach vulnerable populations, continuing to measure and validate our measures, working on virtual delivery, and looking at dose of interventions. So that is it.
Well, thank you very much, Elyse. I really appreciate that, because I'm oftentimes mentioning the SMART program at McCance, and you've really illuminated details of the program. Any questions? I don't see any questions in the chat yet. But
Peter had his hand raised.
No, I was clapping in applause, but
I don't think I differentiate between clapping and hand raising yet. I have to figure that out. Thank you, Peter.
But I will make a comment, which is that after so many years of hearing about the SMART program and all this work, I had the great fortune of working with Darshan on co-delivering the intervention, where we added a Qigong piece to it to postdoctoral fellows who were doing STEM research. And it was incredible how stressful they are. You know, we're talking about taking care of the caregivers in medicine, but the researchers are no less stressed. And it was incredible to watch the transformation over 8 weeks. I thought, oh, this is, you know, it's a nice program, but it was just so transformative. And we actually used some of the constructs that you shared to quantify these changes, as well as some qualitative research. And it was really transformative. So congratulations on your program. And I think there's so many different applications.
Thank you, Peter. And just to riff off Peter's comment, let me ask a question, Elyse. You've been using the SMART program with, as Peter mentions, frontline clinicians, researchers, patients, parents, family members, and so on. Do you see any differences in terms of outcomes with the SMART program with these varied populations?
I think we see differences in terms of delivery. I don't know in terms of outcomes. Peter asked about data on your postdoc study. We're working on a study of siblings of kids with autism. We worked on a study of parents of kids with autism, and our delivery with siblings is going to be different with adolescents. Our delivery in the community setting, when Christina Saros is working with older women with HIV, is going to be different. We have modifications in terms of how we deliver it. When we made modifications during COVID to work with frontline clinicians, we changed our delivery. So I don't know that I think that the outcomes are similar in terms of increased support and decreased loneliness and increased sense of mindfulness and stress coping and resiliency. I mean, we see, interestingly, for some reason, empathy we're not ever moving the needle on. We see consistency in what we're not changing. So I think the outcomes are similar. It's just the question of how do we adapt our delivery to the different populations so that we achieve all those outcomes.
Very good. There is a question from Dr. Rand. Do you have any data on the postdoc study that you could share?
That was what Peter mentioned.
Yeah.
Peter, are you guys doing pre-post on that?
We did, yeah, we did do pre-post, and it was a small group, and it's probably not even anything we're going to publish, but we're using it as the basis of something to solicit some additional funds. But informally, I'm happy to share that with the person who asked about it.
We did publish our data on frontline clinicians that was run, our study that we ran 2 years ago at the beginning of COVID.
Very good. Okay, any other questions? Time for one more. Great. Well, thank you very much, Elyse.